All right, everyone, welcome back. So today we're diving into like a really fundamental and important topic in removable partial dentures, and that's major connectors. Whether you're designing a Kennedy Class 1 or like a Class 3 case, choosing the right major connector is honestly absolutely essential for the success of your prosthesis. So let's just take our time today and go through everything you need to know, like what they are, their function, the design principles, and of course the different types for both the maxillary and mandibular arches. So what exactly is a major connector? I mean, in simple terms, it's basically the primary framework component that like unites all the parts of the removable partial denture. It connects the left side to the right side, the anterior components to the posterior ones, and it provides the rigidity that's needed for the whole prosthesis to actually function as a unit. And if that connector flexes or bends under occlusal forces, then yeah, the denture fails. You start getting instability, loss of support, soreness, and eventually like damage to the abutments or the soft tissues. The material used is almost always cobalt chromium alloy. It's strong, lightweight, corrosion resistant, and allows for these like thin but rigid designs. Now, when it comes to design principles, there are a few rules that you really have to follow. First, the major connector has to be rigid, like that's non negotiable. Second, it shouldn't rest on movable tissues. We only want to place it on firm, stable surfaces like the hard palate or the lingual surfaces of the mandible. Third, you need to give it adequate relief to avoid impinging on soft tissues, especially near frena or undercuts. And like last but not least, when crossing the midline, it should be done at right angles to make sure stress is evenly distributed and the rigidity is maintained. So let's start with maxillary major connectors. We'll begin with the palatal strap, which is like one of the most commonly used designs. It's basically this broad, thin band of metal that runs across the palate, and it's ideal for short span, tooth supported cases like Kennedy Class 3. It offers excellent rigidity because of its wide surface area, and it's actually pretty comfortable when it's designed properly. Now, when you need more support and rigidity, especially like in bilateral distal extension cases like Kennedy Class 1, we usually go for the anteroposterior palatal strap. This one has a narrow anterior strap and a posterior strap connected by these longitudinal elements. It avoids covering too much of the palate, but still gives you like excellent rigidity through its kind of closed circular design. Then we've got the complete palatal plate, which gives the maximum palatal coverage. This one's indicated when like a lot of teeth are missing or when the remaining teeth have poor periodontal support. Because of its broad contact with the palate, it provides like the highest level of support and stress distribution. But yeah, since it covers so much tissue, it can sometimes feel bulky or less tolerable for some patients. So like you really need to keep that in mind. Now, the horseshoe connector or a U-shaped connector is one that like a lot of students tend to pick when there's a palatal torus. And yeah, it is actually indicated when you've got like large, unremovable tori or strong gag reflexes. But keep in mind, it's the least rigid of all the maxillary connectors. So you only want to use it when like there's no other design that'll work. Because of its open anterior part, it flexes more, and that can lead to long-term failure if you're not careful. Then there's the anteroposterior palatal plate, which is kind of a hybrid. It gives you the rigidity of the anteroposterior strap, but like with a bit more palatal coverage, though it's not as bulky as the complete plate. It's a really solid option when you need strength and coverage, but still want to avoid the rugae or anterior palate for patient comfort. Now, something that's kind of unique to the maxilla is this thing called beading. So, beading is like a little zero point 0.5 to 1 millimeter depression that we carve into the master cast at the edges of the connector. Why do we do that? Well, for two reasons. First, it provides a tight seal between the metal and the palatal tissues, which helps prevent food impaction. And second, it creates a smooth transition between the metal and the tissues. So, yeah, it ends up being more comfortable and hygienic for the patient. All right, let's move on to the mandibular major connectors. So, here the most commonly used design is the lingual bar. It's basically just a simple bar of metal that runs along the lingual surface of the mandible. For this to work, though, there has to be at least 7 millimeters of vertical space between the gingival margin and the floor of the mouth. That allows for 4 millimeters of bar height and 3 millimeters of clearance. It's minimally invasive, super comfortable, and that's why it's preferred whenever you've got the space for it. If you don't have enough vertical space, we go for the lingual plate. This one covers the lingual surfaces of the anterior teeth and extends up to the cingula. It's more rigid than a bar and allows you to like splint anterior teeth together. It's also a good pick if you think your patient might lose more teeth in the future and light, since you can add teeth to it pretty easily. There's also the double lingual bar or Kennedy bar, which includes the regular lingual bar plus a second bar that runs along the cingula. This helps improve indirect retention and bracing, especially when the anterior teeth have like open embrasures or are periodontally compromised. Sometimes, like if the anatomy just doesn't allow for a lingual design, like there's a really high lingual frenum or tori, we can use a sublingual bar. It tucks in below the mylohyoid ridge. It's more technique sensitive and honestly not used that often, but it's still something you should be aware of. Lastly, in super rare cases where the lingual side isn't accessible, maybe because of severe crowding, missing canines, or some big anatomical issue, we might use a labial bar or a swing lock design. These place the bar on the labial surface and use a locking hinge for added support. They're not like aesthetic at all, but sometimes they're the only viable choice. And that, in a nutshell, kind of covers the major connector designs for both arches. So, yeah, just remember the connector isn't just some passive bridge between components. It's like the structural core that determines how stresses are distributed, how the denture functions, and ultimately how your patient feels while wearing it. Thanks for sticking around. If this was helpful, give it a thumbs up and drop your questions in the comments. I'll see you in the next lecture.